Regardless of where you work in the world, the chances are if you go into your ICU today, you'll find a few patients at least on pressure support ventilation. It's an interesting mode, and I think it's a really good starting point for understanding all pressure limited modes. The reason for this is there are nuances to pressure support that are often missed by bedside practitioners. So this is a mini module that covers pressure support, starting with the triggering of the breath, going through to the initiation of the breath, the mid-range flow, and then how the ventilator cycles. In the middle of that, of course, we look at how you target your tidal volume with pressure support. So this is our first talk on pressure support, part 1. Tutorial 8. Pressure support ventilation, part 1. Triggering pressure support. Previously, we visited volume control modes of ventilation. We looked at volume assist control and why you might use this particular mode and what problems you might encounter while using it. And then we moved on to look at synchronized intermittent mandatory ventilation. This has traditionally been used as a volume control mode with pressure support, but it can be used as a pressure control mode as well. And I talked about why you might or might not use this particular mode in the ICU and the operating rooms. We subsequently moved on to look at some applied respiratory physiology that I believe is absolutely essential if you're going to work in intensive care or indeed anesthesiology. And I particularly looked at hypercarbia and what causes hypercarbia, the difference between alveolar and minute ventilation. We looked at the alveolar gas equation and then looked at anatomic and physiologic dead space. In this tutorial, I'm going to introduce the concept of assisted spontaneous breathing, and we're going to focus on one mode of ASB, and that is pressure support ventilation. And we're going to revisit triggering. In particular, we're going to focus on two issues that occur with triggering, and they are undertriggering and overtriggering. The typical scenario you might encounter would be Eddie, who is brought to the ICU intubated but breathing spontaneously. Eddie could also be in the operating room, having been paralyzed at the beginning of the operation. Now he's beginning to breathe up. So he's a spontaneous breathing patient. And when we're looking after a spontaneous breathing patient, we need to think about what we're trying to achieve. We need to apply a mode of ventilation that will assist his spontaneous breaths, and that will ensure that we meet our PaO2 and PaCO2 goals. We need a mode that will overcome the work of breathing through the endotracheal tube, and one that is relatively comfortable for the patient. And what I mean by that is that there isn't patient-ventilator dysynchrony at the beginning of the breath, in the middle of the breath, and at the end of the breath. Recall the problems associated with IMV ventilation, and indeed with anesthesia machines, where there is significant amount of flow going past the tube, but when the patient needs to draw gas, they need to draw gas down the expiratory circuit and through a bag because their peak flow demands more gas than is coming specifically out of the outflow valve. So there has to be some kind of a reservoir, and that reservoir is the expiratory circuit and the bag. And that's a fair amount of work for the patient to generate if they're breathing through an endotracheal tube. Remember that when we're measuring pressures on modern circuits, the sensors are here at the Y, and I'll refer to that a little bit later on a couple of times. But it's important to realize that when you're measuring airway pressure and flow, those measurements are not happening in the patient, they're happening outside the patient. And ideally, you would really want them to be measured at the carina or just above the carina at the end of the endotracheal tube, but that is really difficult to achieve. So be very careful about what you think you're giving your patient. Now, a lot of these issues were resolved with ICU ventilators and the use of modern triggering systems such as Flow-by. And these triggering systems allow for assistance for the spontaneous breath, and they're based on control of flow. And when gas travels from high pressure to low pressure, flow occurs, and there must be a pressure gradient. Even simple Flow-by must have some kind of pressure gradient, and so a small amount of positive pressure must be delivered to the airway when the breath is actually delivered. A lot of that pressure will dissipate though as gas works its way down the endotracheal tube. In this example, you can see that I've attached a pressure and flow sensor cable to the Y. The Y is the connector of the breathing circuit to the endotracheal tube, and the gas is flowing in inspiration. This generates a nice positive pressure waveform on the screen and a nice flow waveform as well. And these are quite conventional looking, a positive pressure waveform, positive and then negative flow waveform. Now let's add a second screen and a second pressure and flow sensor at the tip of the endotracheal tube. Now you can observe the pressure waveform and the flow waveform at that site, and it looks totally different. These are sinusoidal flow patterns. This is the flow pattern I introduced in tutorial 2. This is not a positive pressure flow pattern. This is what you see with spontaneous ventilation. And because the airway pressure is raised above atmospheric, we can call this CPAP. So this patient is getting CPAP. And what's happened here is the positive pressure that had been delivered at the Y has now been lost by the time the flow has gotten to the tip of the endotracheal tube. Depending on the tube, this may be 5 to 7 centimeters of water, and it's caused by tube resistance principally. That tube resistance is factored into the length of the tube, the flow grade, the pressure gradient on either side of the tube, and of course the radius of the tube. In the past, we used to insert very large tubes to overcome this, for example, size 9 tubes in most men, but we were a bit concerned about airway complications such as strictures in the trachea. Sometimes we cut the tube, but that led to a problem of accidental extubations and ulcerations around the lip. It's also worth noting that with modern machines, modern ventilators, the base flow, which cannot be turned off, will deliver about 1.5 centimeters of water of pressure assistance regardless of what spontaneous mode you are using. When we look at assisted spontaneous breathing, we need to think about what we're trying to achieve. Firstly, we're trying to achieve patient comfort, overcoming the work of breathing through the endotracheal tube or tracheostomy. We may be using it as our primary mode of ventilation, in which case pressure-limited ventilation is given to the patient with mild to moderate lung compliance problems. Certainly someone with very poor lung compliance with severe aords will find it very hard to inflate their lungs because their lungs are essentially concrete. So you're usually looking at patients who are either recovering from aords or have moderate levels of lung disease and the lungs are reasonably compliant. And finally, it can be used as a weaning mode where you regressively reduce the support as lung function improves. In terms of the different modes of assisted spontaneous breathing, well, for patient comfort, you have a choice really of two things: pressure support, or its analogy, which is volume support. I'll talk about that later, or tube compensation, where the ventilator has a bunch of algorithms that it uses to look at a flow resistance through the endotracheal tube, overcomes this and delivers sufficient support and flow that the patient doesn't have to work to breathe. As a primary mode of ventilation, you have pressure support and volume guaranteed pressure support. In this situation, the patient, you tell the ventilator how big a tidal volume or a small tidal volume the patient needs, and it automatically adjusts the pressure support from breath to breath to make sure that they get that. And finally, we have a weaning mode, which is either pressure support ventilation or volume support or proportional assist ventilation. That's a variant of pressure support. But what's useful to notice is that for all of these, pressure support ventilation as a standalone mode works perfectly well. And that's why I'm going to talk specifically about pressure support in these two tutorials, as it's widely used It's relatively easy to get started with, and a lot of people think they know a lot about pressure support because it's so easy to use initially, but there's a lot of nuance with this mode of ventilation. It's quite tricky, and it's really important if you're using this a lot in the ICU that you understand the nuance. Another thing I really want to get through is that please use the correct term here and respect the mode. It is a very widely used mode of ventilation. The term to use is pressure support ventilation. Please do not say CPAP stroke pressure support, as frankly that is a little bit ridiculous. And please don't use proprietary terms such as assisted spontaneous breathing. This is known as pressure support ventilation, and that is the only term I'm going to use with reference to the specific mode that is pressure support in these tutorials. So it's a pressure limited mode. Flow is generated until the airway pressure limit is met. It's always patient triggered, and it can be a pressure trigger or it can be a flow trigger. Flow is variable depending on the patient effort. The greater the patient effort, the greater the flow. Tidal volumes, consequently, are also variable depending on patient effort. And the ventilator always cycles to exhalation at a specific percentage of peak flow. This is known as E-sense, expiratory sensitivity, and it's known as flow cycling, as we mentioned in an earlier tutorial. So flow cycling is a key component of pressure support ventilation. When we set up pressure support, we set up, like in all modes of ventilation, the inspired oxygen, tension, PEEP if it's needed, and then we set up our pressure ramp, which is our pressure support or inspiratory pressure level. Then we need to set up the initial ramp. This is how the breath goes from zero flow to peak flow to the pressure target. So that's the initial ramp. I'm going to call that the rise time in this particular tutorial because it's easier to have specific terms for these things. You need a trigger, which can either be a pressure trigger or a flow trigger. And finally, a way of switching off the ventilator, letting it cycle from inspiration to expiration. And this is known as expiratory sensitivity. In tutorial 1, we're going to talk about setting the pressure support level and triggering the ventilator to give the patient a breath. In tutorial 2, we look at the ramp and the expiratory sensitivity and all the kind of stuff that goes with that. When we're setting up pressure support, we need a patient trigger. We need to be careful about how this is set. We need to choose between flow or pressure triggering. We also need to set a pressure limit. That may be untargeted. For example, if the patient is on SIMV and SIMV is giving the patient his or her minute ventilation. But if the patient is breathing exclusively on pressure support, we need to target a specific tidal volume. And the flow rate, the initial and peak flow, and the expiratory cycle is determined by the transpulmonary pressure. And this is often forgotten by the operators of ventilators who are using pressure support. So I'm going to cover this vast swathe of stuff in these 2 tutorials. The first thing, though, that I'm going to talk about is triggering. We discussed triggering in tutorial 3. I'm going to go into it in slightly more detail here because really you can't understand pressure support unless you understand triggering. So Eddie has put on pressure support ventilation. The pressure support level is 10 centimeters of water above PEEP. We also set a flow trigger of 5 liters per minute. Now on a Puritan Bennett ventilator, that's 6.5 liters per minute because it has a base flow of 1.5. We've also set an expiratory sensitivity of 25%. This is Eddie's waveform on his pressure waveform. Now it doesn't look right. Eddie is clearly breathing on his own and triggering breaths. But you can see small divots on the pressure waveform that do not result in breaths. He is intermittently failing to trigger the ventilator. He is under-triggering. Let's just revisit flow triggering. Flow triggering or flow-by was developed to make it easier for the patient to trigger a breath. In this cartoon, we have an endotracheal tube, we have the Y, and we have a breathing circuit. The pink blob there is the patient. Imagine this circuit goes all the way around, but I've just left it as a single column. Let's send a base flow through this system. That's 2 liters of flow. It passes an inflow sensor, then it passes an outflow sensor. There's the inflow sensor, there's the outflow sensor. Because flow was not deflected, either not at all or insufficiently during that flow through the system, the ventilator does not trigger. We don't pass sufficient magnitude of flow being deflected into the patient to quantify that a breath should be given. And that's likely what's happening with Eddie here. He doesn't take big enough breaths with the amount of flow by that is being dialed up to trigger the ventilator. In this example, the patient does draw a flow of gas from the circuit, and the return flow is lower than what went out. So the add-flow sensor is activated. It tells the ventilator that there was a specific level of flow deflection. If it reaches the magnitude required to trigger a breath, the ventilator will trigger and the patient will get a breath. When you look at trigger sensitivity, it can be quite confusing because there are 2 main models used out there. One of them is the Puritan-Bennett model, and the other is the Servo model. But these can be used by different manufacturers, and I'm not giving these manufacturers credit, it's just as these are the models that I see in my practice. In the Puritan-Bennett model, a specific volume of gas is drawn to trigger the ventilator. In the Servo model, a specific proportion of base flow is drawn to trigger. As a consequence, when you're looking at these ventilators, the higher the V-sense is set on a Puritan-Bennett ventilator, the harder it is to trigger. Remember that Eddie had a V-sense of 5. That's pretty high. It's going to be difficult for Eddie to trigger the ventilator. On a servo ventilator, the lower the proportion of base flow, the easier it is for him to trigger. Let's look at flow-by in this particular setting. And on the top of the screen there, you can see that the flow sensitivity has been set at 5 liters per minute. Here at the bottom, there's a red dashed line set at 1.5 liters. On a Puritan-Bennett ventilator, this is the base flow. This is always delivered in all patients all the time, and you cannot change it. It's the base flow. Above this, we are setting a flow sensitivity or V-sense of 5 liters, meaning that the total flow is 6.5 liters. And frankly, this is a lot. We have 2 windows. We have the base flow window and we have the flow-by window. In order for Eddie to trigger a breath, he must inhale sufficient volume to interfere with the 1.5 liter base flow. That's what the ventilator is interested in. The 1.5 liter that it sends out all the time and the 1.5 liter that it brings back. In between, we've added a bit of extra volume and flow to the patient, but the ventilator is only interested in this 1.5 liter. The additional 5 liter is a big ask because Eddie must suck his way all the way through that to hit the base flow. So let's roll the animation. Now you can see here that Eddie is clearly breathing on his own. The first breath does not reach the magnitude of entering down into the base flow, and as a consequence, he will not trigger the ventilator. The second breath, though, is a stronger breath, and it goes down into the base flow, and this results in a trigger of a breath. And this is why Eddie is under-triggering. The flow sensitivity is set too high for him. So in the Puritan-Bennett system, a low flow of 2 liters per minute and a high flow of 5 liters per minute have very, very different effects. With the low volume that you need to take from the low flow, it's much easier to trigger. So that's adding 2 above the 1.5. Whereas the high volume associated with the high flow makes it hard to trigger. That is 5 liters above the 1.5. Now you may decide, well, let's be nice to Eddie here and let's reduce his flow sensitivity down to 2 liters per minute. Let's make it easy for him. Why are we making it so hard for Eddie to breathe? And so we turn the knob and down goes the flow sensitivity to 2 liters per minute. And look what happens here. You can see here there's a lot of jitter going on and a lot of breaths going on. And what's happening here is that Eddie is over-triggering the ventilator. Now, over-triggering can happen for all kinds of reasons. For example, a very big chest thrust from large cardiac auscultations will do that. Also, moving the patient around in the bed causes changes to the shape of the chest, and this may cause the ventilator to trigger. So you need to be very careful that you don't set the sensitivity so low that the patient is getting a breath when they don't actually need one, or else the patient takes these little panting style breaths and they get so many breaths that they start getting hypocarbic. So this is too much, right? So we need to readjust again. So 2 liters is just too little flow. He's triggering the ventilator too much, and this is problematic. So we change it now to 3 liters, and this is what we see, and this is just gorgeous. Every breath is resulting in a nice pressure waveform, and Eddie is getting a nice minute ventilation without over-triggering. Let's illustrate this. In this scenario, the base flow is 1.5 liters per minute. And we've set the V-sense at 3, meaning that the total flow is 4.5 liters per minute. To trigger the ventilator, the patient demand must exceed 3 liters per minute. And that is the fundamentals of how trigger sensitivity with flow-by works in that model of ventilator. But there is another system, and that's the servo system, where a specific proportion of base flow must be drawn to trigger the ventilator. And that base flow is always 2 liters in the modern version of this ventilator. The confusing thing is the lower the proportion of base flow, the easier it is to trigger the ventilator for the patient. So this is the Servo-i ventilator. The base flow is 2 liters per minute or 33 mils per second. And you can see there that the trigger flow has been set at 5 in this ventilator. Let me try to illustrate this. I've drawn 10 boxes numbered 1 to 10 to represent the settings on the servo ventilator. In reality, the colors change from green to red along the way. Into the system is a bias flow or a flow-by of 2 liters. If I select 1, that means that the percentage of bias flow that must be deflected to trigger the ventilator is 100%. Remembering that the bias flow is 2 liters or 33 mils per second. If I set 2, the bias flow that needs to be deflected is 80%, 3, 70%, 4, 60%, and so on, all the way down to 1%. Selecting 1 in this situation requires that 100% of bias flow must be deflected. And that is 2 liters per minute, and that's relatively hard. So this is the hardest level 1. And there's a risk here that the patient will under-trigger. On the other end of the scale, we have 10, where only 1% of bias flow must be deflected, and that's 0.02 liters per minute. So it's ridiculously easy to trigger the ventilator, and there's a high risk of auto-triggering, particularly from cardiac oscillations or people moving the patient in the bed. At 5, only 50% of bias flow, or 1 liter, needs to be deflected. So this is the mid-range here, 5. It's not a lot. In this example, we sent our 2 liter bias flow through the system with 5 drawn up. The patient draws in the equivalent of 1 liter per minute. This is sensed by the outflow sensor, and the ventilator triggers. And that's what's happening here at 5. So the patient is triggering very nicely. If we were to go up to, say, 7 on the scale, well, that 7 is lower, right? So 7 is actually easier to trigger than 5. At 5, we only needed to displace 50% of bias flow. At 7, it's 30% of bias flow that needs to be deflected. One of the nice things that I like about the servo screen is that when the patient triggers the ventilator, you see this lovely little purple T that shows that the patient is triggering. Sometimes you see an S on other ventilators, and there's a purple line, a purple upstroke on the flow waveform to illustrate that there has been flow triggering. In summary, if you're going to use flow triggering, you need to identify how patients trigger breaths on your ventilator when using flow-by. Do they draw a specific volume above the base flow, or do they draw a specific proportion of the bias flow? What vent changes do you need to make it easier to trigger the ventilator? And think about what changes you need to make it more difficult to trigger the ventilator. Let's move on to pressure triggering. If, for example, we're finding it difficult to get Eddie set on flow triggering, we may consider pressure triggering. And although many consider pressure triggering to be a dated concept, I disagree. While it appears that flow triggering has some advantages over pressure, particularly it is easier to really fine-tune flow triggering, there are other things to consider, particularly the amount of gas that may be wasted using flow triggering. Not that far in the past, we had a global pandemic where hospitals may have had several hundred patients on mechanical ventilators simultaneously, and the oxygen supply to that hospital was precarious. The last thing that we needed in those situations was to be venting out gas into the atmosphere unnecessarily because of dialing up at fairly high levels of flow-by. And that is particularly the case if the patient is paralyzed and not interacting with the ventilator on volume control or pressure control. Very hard to set up these without having some form of assistance. So using 2 to 5 liters of flow-by is just wasteful and pointless in that scenario. There's a lot to be said for pressure triggering. It doesn't require continuous gas flow, not for all ventilators, but for many ventilators. It works fine in the majority of patients, particularly those who have good respiratory drive. And, if the drive is really bad, there are alternatives to flow-by, such as NAVA, neurally assisted ventilatory control. And so flow-by isn't a panacea. It's good for the majority of patients, but there are some at the extremes that it's not great for. And one of the final good things I find about pressure trigger is that if a patient is over-triggering, and we saw a lot of this during COVID-19, patients very very strong respiratory drives. We also see it in some neurosurgical patients. Well, they have a tendency to overtrigger. Pressure triggers are often easier to sort these problems out with. In this example, we have set a pressure trigger. You'll notice that the trigger switch is now changed over to P-trig, and the pressure level is illustrated there on the pressure waveform by a red dashed line. The sensor is located on the Y. When the patient generates a breath, if the negative pressure deflection is of sufficient magnitude to trigger the ventilator, then the ventilator will deliver a pressure support breath and an S will appear on the screen. And we can see the typical pressure support flow and pressure waveforms on the screen here. For most ventilators, and in this example I'll use the Servo-i because it's got a nice little picture on the screen, the pressure trigger works between 0, which is no negative pressure, down to -20 centimeters of water, which is pretty much close to impossible for most patients that might require mechanical ventilation. The greater the negativity of that number, the harder it is to trigger. And on the Servo, the purple color indicator is on the pressure curve, not the flow curve. On this pressure waveform display, we're going to set the PEEP at 5 centimeters of water, which means that the airway pressure must drop below that level to trigger it. We're going to set the negative pressure trigger at -2. That means that the airway pressure must drop to 3 centimeters of water or below to trigger the ventilator. Let's just see what happens with Eddie. Well, this looks familiar, right? You can see that Eddie is over-triggering the ventilator, and this isn't good. So we need to reduce the trigger sensitivity. Do we go, for example, to -1 or to -3 or below? What do you think? Well, in this situation, we're going to reduce the sensitivity, so we've turned it down to -4. And that means that Eddie needs to generate negative pressure of 4 centimeters of water below the PEEP level to trigger the ventilator. Well, let's see how Eddie gets on here. So he does trigger that breath, then he fails, then he triggers, then he fails, and he triggers, and he fails. And this is under-triggering. It's really, really ugly looking. So this isn't good either because Eddie's working kind of hard and he's trying to take breaths, but he's not getting them. So here he's under-triggering. Let's make a further adjustment. And let's set the pressure trigger to -3 centimeters of water. Now the patient needs to generate -3 to trigger the ventilator. And let's see what happens here. And you can see here that this has been successful. Each breath that he tries to take has resulted in a breath being triggered, and we have a nice match between the trigger and the airway waveform, so that little divot is matched by a nice takeoff on the waveform. So this is a nice patient-ventilator interaction. In summary, pressure triggering should be considered if you're concerned about wasting gas where resources are very limited. If patients are paralyzed or not interacting, they will not trigger, and accidental triggering can occur. And so it's important to set an impossible negative pressure level on these patients, because really, really sick people, the last thing you need is the ventilator triggering itself. Alternatively, in patients who have very strong inspiratory effort and easily trigger the ventilator, there is nothing to be lost except gas by using pressure trigger. So it's something to consider using if you're concerned about how much oxygen you have available to you. Let's review this tutorial. In this tutorial, we discussed assisted spontaneous breathing and the indications for assisted spontaneous breathing, specifically pressure support ventilation. we looked at triggering pressure support, particularly flow versus pressure triggers, and why both of them are valid for use in modern critical care. I discussed undertriggering and overtriggering and things that you can do to resolve these problems. In the next tutorial, we will look at the initial flow of gas immediately after the ventilator has been triggered in pressure-limited breaths. We will look at one specific ventilator setting, the slope of the inspiratory flow curve, otherwise known as the rise time. We will then briefly look at the mid-range flow and dysynchrony during that period when the breath has already been established. I'll see you then, and I guarantee you'll learn something. Well, that completes the first tutorial on pressure support. If you enjoyed this tutorial, please give me lots of likes and subscribe to the channel. And I'll be moving on the next time to part 2 of pressure support. I'll see you then, and I guarantee you'll learn something.